Compassionate Ottawa acknowledges that we are located on the unceded and unsurrendered territory of the Anishinaabe Algonquin Nation. We work here and we pay our respects to Indigenous elders, past, present, and emerging. Conversations with Leaders is proudly sponsored by Sapiar Wealth Management of RBC Dominion Securities. So Compassionate Ottawa is a movement that builds the capacity of the citizens of our city to be more confident, capable to help themselves, their families, and people in their communities to live well, die well, and grieve well. We work with others to change attitudes about death and dying. We encourage building networks of care in order to tackle loneliness and isolation. And we do that through workshops, through conversations, through research, and some special projects. We work closely with others in the community to learn about community issues, such as the one we'll be talking about today, Compassion on the Streets of Ottawa. All of our work is intended to build capacity among individuals, their families, and the community as a whole, so that everyone can live as well as they can and as long as they can. I'm really delighted this morning to introduce Jack McCarthy. He's the Vice Chair of Compassionate Ottawa, and he was the Executive Director of Somerset West Community Health Centre from 1989 to 2016. Jack has always been passionate about community development, and he did many, many things in his career to further that goal. He was a chair of the National Association of Community Health Centres. He was a chair of the Coalition of Community Health and Resource Centres here in Ottawa. For as long as I've known Jack and known of Jack, because I certainly knew of him before I met him personally, he has been a champion of social justice in our community. He embodies compassion and the values of Compassionate Ottawa. I've always been impressed with Jack's humanity. He's genuine and he's a down-to-earth human being. I know he will engage us in a wonderful conversation this morning with Dr. Jeff Turnbull. Welcome, Jack.
Well, thank you. Thank you very much, Louise, for that very kind introduction. It's my pleasure now to introduce Dr. Jeff Turnbull. And in this conversation with Leaders today, just by way of background, Jeff received his doctorate of medicine at Queen's University and specialty education certification in internal medicine in 1982. Over the years, Jeff has been in a number of leadership roles, including the Vice Dean of Medical Education at the University of Ottawa, the President of the Medical Council of Canada, the President of the College of Physicians and Surgeons of Ontario, and the President of the Canadian Medical Association. At the Ottawa Hospital, Jeff was the Department Chair of Medicine from 2001 to 2008, and the Chief of Staff at the Ottawa Hospital from 2008 to 2017. Jeff was also the Chief of Clinical Quality for Health Quality Ontario, where he also held the position of Health Equity Clinical Lead. He also served as Senior Medical Officer for Correction Services Canada 2011 to 2014. Jeff remains committed as a medical educator with special interests in poverty and health equity. And Jeff has pursued an interest in poverty and its effect on health nationally and internationally. He is one of the founders and is currently the medical director of Ottawa Intercity Health. He was also a co-founder for sure, whose mission is to improve the health of people who are chronically homeless. And in 2007, Jeff received the Order of Canada and has received many other impressive awards. Welcome, Jeff. It's really nice to be with you in conversation.
Thanks, Jack, for that very flattering introduction. Not sure who you were talking about, but that sounds great.
I forgot to mention, you're also a farmer close by up on the Quebec side. So that's an important part of your resume as well.
Yeah.
Yeah. Just to kind of start us off in this conversation, tell us a bit about what Ottawa Inner City Health is all about, and how you got involved in this organization, moving from like a big hospital to a frontline health service organization targeting the homeless. Tell us a bit about that story.
Well, Jack, it's best to start at the beginning, I think. And some 20 years ago, a group of us who were involved in providing services to those experiencing homelessness recognized that those individuals did not have the same access to quality health services that you and I would expect. And we got together and felt that there was a need for us to develop a new model for healthcare for those individuals. And since that time, I'd like to say that we were thoughtful and knew exactly what we were doing, but that's far from the truth. We were led by that community. We reacted to the changes that were taking place so dramatically around us. And subsequently, Ottawa Inner City Health has grown dramatically to a point now where it's an integrated health system for the homeless, where we deliver care that they need, where they need it, and when they need it. So that care is right in the shelters, on the streets, under bridges, in fields, right throughout our city for the 1,000 individuals who are experiencing homelessness every night in Ottawa. And so we provide health promotion strategies, primary care, secondary care, and tertiary care in some circumstances right in the shelters where they are. And we started off with a small number of providers, and now we've grown to hundreds of different providers of different types that provide those essential services. And so it's been a wonderful collaborative partnership between different organizations that deliver care that is more compassionate, more effective, and cost effective. It saves money delivering care, and the care is now, it works. It's better for these individuals. I can't say as we've solved the problem of homelessness, but we've certainly improved the quality of their care.
No. And I'm sure as you've touched the lives of so many people in that community of homeless folks in downtown Ottawa, and people who have connected to Inner City Health. And I'm wondering if, as a frontline physician who has connected with some of these folks, if you could just tell a few of the stories of some of those people who've touched you in a very special way, and I'm sure, you know, taught you things as a physician, but also, brought out the kind of humanity and the kind of engagement we have with folks who are so marginalized.
Yeah. I mean, you must know this too, Jack, from your experience, but I mean, I would have to say that I've benefited much more and learned much more from this community than I've ever contributed in terms of health services. They teach me every day. I'm constantly reminded that, well, I just don't understand. And when a conversation begins like that, I know that I'm about to get put in my place, which is almost always correct. Unfortunately, have to say that. Stories, everyone has their stories. Some are filled with tragedy and some are often humorous, etc. But I tried to think of a couple ones where I've been taught most prominently. The first one was, people might have heard me talk about Normie, but Normie was found on the street of King Edward and was naked on the street, winter and was brought in. And fortunately, right beside that is our palliative care unit at the Union Mission. And we admitted Normie to the palliative care unit. He'd been released from my hospital, the Ottawa hospital, where he was, in quotation marks, dying. And we put him in our hospice there, and subsequently treated his medical illnesses. And in fact, he was not dying. He was he had chronic illnesses that could easily be managed. And but to be managed, they had to be managed in a stable environment. So, and he improved dramatically there, and to the delight of everybody, got better, gained weight, was a great guy. And then I was given the unfortunate task of telling him that he was in a hospice or a palliative care unit and was not going to die. And then he had to leave. And he said, you know, you really can't get me to leave. This is the only place where I felt safe and at home. And the interesting part of that story is we found a place in the 4th floor of the Union Mission for him, and where he stayed there. And he told me one day he was bored. And I said, Normie, what would you like to do? And he said, oh, I like to paint. And so I said, great, I'll bring some crayons and paper for you next time I'm by. And he said, no, you're on your way to the women's shelter. I'll go with you now. And we went, and for anybody who know where, there's a place called Waldex along that route. I didn't know what that was, but it's a artist supply store. And Normie's buying cobalt blue acrylics, and he's buying canvases and stuff like that. And I said, Normie, I really can't, this is expensive, this stuff. And he said, don't worry, I'll paint a picture just like I have in the National Gallery for you. So the next morning, we're sort of joking around with the nurses. And I said, you know what Normie said? And said, we're going to have to change his medications, And the nurses quickly pulled out their computers and searched Normie. And he does not have a painting in the National Gallery. He has 2 paintings in the National Gallery. He has a coffee table book and everything. And he had a tremendous history of trauma in his past. And he taught me never to judge, and about forgiveness. And he taught me that everybody had the right to quality health services and a safe, protected environment. Jack, you asked me to think about 2 cases, and I think the other case is a little bit more tragic and highlights a bit more of my weaknesses more than anything. And this was a fellow who was entered into one of the first people we entered into a managed opioid program. And I can talk about that later, but the managed opioid program was a reaction to the toxic drug supply. And we were actually he was an opioid fentanyl user. We were giving him prescription opioids to stabilize him. And but he was dealing with those. And that was a no-no for us. And that was one of the rules. And he continued to do that despite pauses and, cautions, etc. And I sat with him one day and said, you're going to have to leave the program. And he just turned to me and just said, so that's it. So now I die. And I thought that was kind of a little bit of drama. And the next day he was dead of a drug overdose, going back to fentanyl. And he taught me that my actions had consequences. He taught me humility. And he taught me that the rules that I created were just the same rules as hospitals or other institutions that really just did not understand his circumstances. And I did not understand his circumstances, and he was the one who paid for that. And so I think very often about Cody. But I also can think of lots of circumstances of, great humor and compassion and fun on the streets. But those were two circumstances that perhaps I learned the most from.
Those are, Jeff, those are two very powerful stories. And wow, and just your point about, to better understand, to never judge, to forgive, and the value of humility and all that. And oh wow, and I think when we were setting this up and wanting to explore compassion, I mean, this is really touching, I think, on what this compassion is all about on the streets of Ottawa, and it makes me want to just get your thought on, this is a bit of a deviation maybe, like when we walk downtown in Ottawa and we see people, I've seen people lying on the street. I've seen people just, cowering and looking down and begging for money. I've heard people yell and scream as well. And I remember this was actually in Toronto when I saw this young man who was holding a sign. And the sign, as he was crouched on the sidewalk, was, I am not a bad person. I'm just really hungry and need some food and some money. And it kind of just made me feel so sad. But then I started to reflect on, when I walk and see people, sometimes I give money, sometimes I don't, sometimes I'm in my own headspace and not knowing what to do, sometimes I'm not very present. Do you have any thoughts, reflections, or advice? Because I suspect many people listening in, we're confronted with that and it makes us feel uncomfortable, and maybe we walk away, and I'm never sure what the right way to deal with that is.
I'm asked that question a lot, Jack. Now, I know most of these guys, so when I see them on the street, they suddenly will recognize me and they'll just wave or whatever, and we'll have a chat, or sometimes they'll jump in the car. They know my children, and so they'll say hi to them, etc. And it's like sort of a old home week when we see them on the street. So it's different for me. I tend not to give them any money. But what they really want is somebody to just recognize them, just say hi, wave to them, understand that they're there. They feel every day invisible. They feel, the disrespect, the anger, the transparency that they have every day from society, the contempt from society. They feel that tremendously. Just a smile, a wave, hi, how are you? Bring your window down and don't be afraid. Just say hi. That's what they really sort of want. Remember, they're sitting there at King Edward and Murray, and I can't describe the world that they live in, and they just see BMWs and Mercedes driving up to their cottages, and those people will just have nothing to do with them. They're not part of their community, and they feel invisible. Just a simple hi is actually probably more important.
A simple hi is, I'd like to move to talking about some of the issues that these homeless folks are dealing with. I mean, for sure, the lack of affordable housing in the city, poverty, addictions, for sure, these are big issues facing the homeless population. Are those the issues that you see, day in, day out? How would you describe, these these big issues that the homeless and unstably housed population in Ottawa are dealing with?
So yes, they are, Jack, you're right. Those are the big issues. They're not all of the big issues. So, I think that the root cause of poverty, and we can go into some of the root causes of homelessness if you want, but what I see every day is the combination of that toxic mix of poverty, of addictions and profound challenges with mental health and prior trauma. And that mix in this community is particularly toxic. And, if you look at it, life expectancy in this community is the same as the Democratic Republic of Congo, 21 years less than people less than a mile away, and so, these people are members of our community. They deserve, as members of our community, better. And we don't give them, we fail them every day. And they live in a world of chaos. There is violence, there is all sorts of challenges that they face, their desperation and sadness and a sense of that they'll never escape. And every day is the same. And listening to their addiction or listening to their mental health issues, and no opportunity and no likelihood that they'll ever move ahead, no hope. But at the same time, Jack, in this community, I see, amazingly, I see happiness, I see courage, I see generosity, humor, and sometimes I wish that the community around them would demonstrate that same degree of compassion that they do for each other. And so it's not all terrible, but frankly, it's just almost impossible, certainly for me, to understand what what life is like there, and what their issues are. And the only way for that is for me just to listen. And so I view myself as somebody who, along with my colleagues, have just developed a program that they wanted, that they led, and we support.
Okay. You mentioned community, and so you're in community and with these folks in the Lower Town East area, like specifically, and it made me reflect on my own involvement in helping to set up a supervised consumption site in the Somerset West catchment area. And more recently, I was talking to some of my former colleagues at both those health centers, and one of the words that came was, there's a lot of chaos now because we have these supervised consumption sites. It's just, yes, people see the pain and people see the gratitude too, but it's brought into the community. And I'd like to get your take on this. We want at Compassionate Ottawa, we think of building compassionate communities. And we know in the communities where we have the supervised consumption sites in this city, there's so much turbulence. How do you reconcile, and how do you build community when, in the case that I'm more familiar with, say in the Somerset West area, where shopkeepers, business people, residents in the area, and some of those residents I've talked to, they said, yes, we should have these supervised, and they feel some compassion for sure, but it's just a really, really tough kind of issue to find some kind of way to embrace everybody. Your thoughts on that?
So this is a tough one. Absolutely. I think we have to go back before the onset of supervised consumption sites and what it was like before, because I think we've kind of forgotten that a little bit. And so remember in the early parts of the fentanyl crisis, when things were becoming just totally out of hand, you could not walk down the street without witnessing several drug deals, people using illicit substances openly in the street, people lying all over, and overdoses occurring in the middle of King Edward and Murray. And, it was Mad Max and the Thunderdome. Like, it was no rules and very, very toxic and violent. And, there seemed to be no end to it. Supervised injection sites focused some of that activity. That's true. But brought a lot of that activity inside in a more controlled and safer environment. And so we now look at this, the climate and the change, what's happened on our streets in the last 3 or 4 years because of that and COVID, is totally different. And so I'm very sympathetic to those communities around that are impacted. And that's why we need to have an overarching strategy for managing addictions and mental health, a community-based strategy that can help everyone. And yeah, we need to move those individuals beyond a safe injection site to controlled and supportive environment where they're not on the streets. It's not good for them either. And it's certainly not good for the community.
No, I remember when I was working, it was important to kind of talk to the peer workers that the harm reduction staff that Somerset West have, and the peer workers, and they'd have their chance to sit down, and I was the executive director, and I was asking them, okay, tell us, what's working, what's not working. And I'm bringing this up because it was an opportunity for me to be able to say that everybody has responsibility to be respectful to people in their community. And people got that, whether you were an injection drug user in a harm reduction program or, other workers, people in the area. We facilitating dialogue and discussion and talking about it. We all got to look after each other. We got to empathize with each other, but we got to be respectful too. So not just the person coming in to do a safe injection, but also coming in that health center, maybe a senior citizen who's just really worried about managing her diabetes, or a mom who has a little kid who's got a bad earache that wants to see the doc. Everybody matters, and that connection and that respect was important. And when you opened up that conversation, I found people they all got it. And they were really good conversations to have.
And in other settings, managed alcohol programs, for example, some of our residential programs that we've now developed right across the city, that support individuals who have moved through crisis to stabilization, transitional housing, and now we're trying to improve the quality of their lives. Those communities have reached out and embraced those individuals. And it's been a two-way benefit because, yes, those individuals help the community, but members of that community, who people in our programs, also reach out and help that community too. So volunteer, etc. So it's a two-way street. And when people enter into that conversation, get to know the people, then it works really, really well. But I understand the difficulty, and you're right. Just coming and talking to people makes a very big difference.
Mhm. I'd like to ask a question, Jeff, about kind of looking at solutions and what are the kind of initiatives that are going to help us move through some of these big challenges, certainly that the homeless are experiencing. And you mentioned about the managed opioid program, that's safe supply and so forth. I mean, these are some of the hot kind of maybe policy questions that are being debated at this point in time. I'd like to get your thoughts on, safe supply. I mean, I think of, we provide safe injection sites, but if people are coming in and injecting drugs that are contaminated, and it's like you're solving one problem, but you seem to be creating another. It's tough. But I think this safe supply notion, and if you could talk about that and why that may be one of the solutions we have to be looking at.
So let's begin with sort of the opioid crisis, and for everyone listening, I think they'd have to recognize that we moved from prescription opioids prior to 2016 to then when there was a definitive move to actually reduce the amount of prescription opioids on the street through regulatory authorities, et cetera, legitimately, but they did it in such a way that there were many people then without access to the usual prescription opioids that they had become perhaps addicted to. What happened then is they turned to the street. And initially there was street heroin, then we moved into street fentanyl. And then the fentanyl became particularly toxic. And there was just about everything mixed in this. And you didn't know what you were getting, and the potency from one day to the next changed. And that's why we were experiencing so many opioid related deaths, up to 11 deaths a day in Canada. And so the safe injection facilities said, okay, well, at least inject here where we can watch you and manage you. And they do save lives. There's no question the one that we administer, the one we call it the trailer. And in that context, up to, on bad days, we're up to 15 overdoses per day that need to be dealt with Narcan oxygen support. So those are people who would otherwise be really sick or perhaps dead. And so they make a difference. Another strategy to try and, let me say, if you just did that and you just said to people, we're going to save your life, we're going to correct that overdose, and then the next day you're going to do it again, and the next day you're going to do it again, we are not changing the trajectory of their lives one little bit, other than we're keeping them alive. So what we need to do is start to combine safe injection with other strategies that are designed to actually move that person in towards a full recovery, if recovery is the direction that they want to go. And so that would be treating their underlying history of mental illness or their physical illness and putting them in a more stable environment, and then start to wrap services around them and actually move them away from this chaotic injection drug using environment. So that, I don't think a safe injection facility on its own right, that alone has to be combined with other services that allow people to make some meaningful recovery that they feel is appropriate for them. Mm-hmm. Now, safer supply is a newer harm reduction strategy. It's to try and deal with the fact that there is such toxicity in the drug supply that if we were able to actually turn the clock back 10 years to back where we had prescription opioids, at least they were not tainted. And at that point, so if we could actually prescribe safe drugs as a way of stabilizing people and moving them away from fentanyl, and then move them progressively to a more integrated recovery strategy that is appropriate for them, then that was the thought. And so sort of safe supply and safer injection facilities go hand in hand as a way of stabilization and moving people into a better place. There's evolving evidence about safe supply that it seems to have a role, and but on the other hand, it's new, it's controversial, but it does seem to be effective.
Mhm.
So we're learning, we're studying it, and we're being supported by the injection drug using community who says this is the way that we want to be cared for.
Mhm. Mhm. And it's saving lives, as you say.
And it's saving lives. And it allows us, I've always said, you can't enter somebody into a treatment program if they're dead.
Mhm. Mhm. This leads me to think about, the homeless population engages with the kind of formal health system, and think of the hospitals, and yet the informal community support system, I'm thinking of harm reduction outreach workers and inner city health, folks at community health centers and so forth, the shelter system. And from your perspective, Jeff, and again as a doc, how would you describe the interface between that formal health system and the informal community support system? And is it working for the homeless population with their burden of illness and so forth?
Yeah, this is this is a phenomenon that I dealt with every day in my professional career. As I would drive from the Ottawa hospital 15 minutes down to the shelters where I was working, and I would be the chief of staff or the head of medicine or whatever it was at that particular time at the Ottawa hospital. Remember, the Ottawa hospital had a budget of $1.2 billion. It had a staff of 14,000, 1,700 doctors, and provided and provides to this day wonderful care. But I would be driving from that 2 miles, perhaps. It was like going to Mars. The world was so different there, and the connection, the outreach, the integration that was needed was just not there. And in part, Jack, probably 5, 10, 15 years ago, it was not considered to be our business at the hospital. We looked after the people who came through our doors. There is a trend nowadays that are, that hospitals with their enormous resources are a resource to the whole community. And they should be moving services out into the community in an integrated fashion. And in fact, it's to the hospital's advantage. So when we started to work with the hospital and diverting ambulances to the homeless shelters where we could care for them better, that saved paramedic time and offloads and emergency visits. And, they're not getting good care in the hospital, in the emergency department anyways. But when we provided that same services through the hospital and engaging the hospital to help us downtown, that's when it really worked. So when we had this integrated system of care with the hospital and the shelters, that's where you saw the greatest improvement in care and improvement in cost.
It comes back to this collaboration an intersectoral collaboration.
And it's hard. And, like I got to tell you that in medicine, we don't collaborate very well within medicine. But now we have to collaborate with other community groups that we've never really partnered with. And you have to learn new strategies and ways of doing it, working with housing and policing and judicial and, all this stuff. And these are communities on their own right that we don't know much about. But to be successful, we've got to be reaching out more. And frankly, I probably have achieved more, or we have achieved more in dealing with, our allied professional partners than we have in treating tuberculosis.
Wow. And from your vantage point, as at one point being the head of the Canadian Medical Association to being now a frontline physician, you've in inner city health, you've been making policy, in from different vantages and different approaches, and you would certainly see, how do you make the change that's going to stick?
Yeah, and that's when it comes from the community and it's developed by the partners to serve that community, then it sticks. And that's why I find working in the shelters so rewarding, is that you do see change at the level of the CMA. You don't see that change. There's such a national perspective. You don't see change that much.
Yeah. Before Paula opens it up to questions from people who have joined in on the call, I have one more question, and it relates to kind of Compassionate Ottawa. And Compassionate Ottawa, and I'm just going to read about the mission, is to build capacity of the citizens of Ottawa to be more capable and confident in helping themselves, their families, and their communities to live well and to die and grieve well. That's what our mission is. And what advice would you have for Compassionate Ottawa in terms of, taking this mission of compassion to Ottawa's most, vulnerable residents?
Well, first of all, I think, the mandate of Compassionate Ottawa is fantastic. We need 1,000 compassionate Ottawas. But what I would argue maybe would be that, well, first of all, let me tell you that when I was the president of the CMA, I was railing on about leadership at the government level in healthcare, and saying that we weren't getting that leadership. And one of the ministers for health took me aside and just said, "You don't get it, really, do you?" And I said, "Well, what is it about this that I don't get? Like, we elect you to make decisions to improve health services delivery, and you're meant to lead." And he said, "Yeah, you don't get it. What has to happen is the community has to come together. The community has to work together in partnership and come with a strategic plan that is supported by the community, and we will follow. We won't lead." And that got me to think about Compassion Ottawa and other organizations, is that it has to come from the community. It has to be the church groups, the Compassionate Ottawa, the Rotary, the business association, all have to say, "We can't tolerate this anymore. You must now follow. We'll make the consensus and we'll show you the path." And then our elected leaders, I think, will follow. But the advice I would give to Compassionate Ottawa is partnerships, reaching out to getting that consensus, and being strong advocates. Perhaps be a little less nice, and forceful, and more forceful, and embracing this community with its warts, with its difficulties, but with its great strengths. I think Compassionate Ottawa is a wonderful organization, and in many ways, I wish there was Compassionate Ottawa within each one of the organizations around us, and that we would all drive change. Because I think I'm hopeful that we can solve this problem. We have to not only just deal with the homeless themselves, that are on our streets in front of us, and put them in supportive housing, but we have to think of the people who are heading in that direction and identify those people at risk, and then have the courage to back up and say, what are the root causes of homelessness, whether that be early childhood development or trauma or mental health, poverty, and let's try and tackle those things so we don't have this problem in the first place.
Yeah, and God knows there's been many reports about the lack of affordable housing that have been written, and task forces that have been set up. But I appreciate your call for Compassionate Ottawa to advocate and to bring people together, to build maybe broader coalitions, if you will, to be pressing on some of these kinds of issues, because that's bringing compassion to the streets, and that is the big challenge of our time.
Yeah, I think so too, and it always worries me a little bit, Jack, that we know that dealing with this problem saves money, improves the quality of care, keeps people out of jails. And so if we're saving money, we're providing better compassionate service, why do we still allow this problem to exist?
No, exactly.
I don't think history will judge us very well in this particular circumstance.
Okay, I'm going to now invite Paula to come back on, and she's going to, I'm sure some of your remarks I suspect will have generated some questions, and so I'll throw it over to Paula.
Well, thank you, Jack and Jeff, firstly, for this conversation. It's been very moving to listen to what you've shared with us all today. And I think the comments that we've been seeing in the chat box reflect that as well. So thank you very much. And to anyone that has a question that they haven't yet submitted, you can do so in the Q&A box on your Zoom screen. We have about 20 minutes to get through some of the questions, and we do have quite a few. So the first one is really a clarifying question for you, Jeff. Do the 1,000 homeless that you spoke of include those who sleep in our city's shelters?
Yes. So those are the people who are registered every night. So in one of our acute shelters. But that does not include the people who are unstably housed, the people who are couch surfing, etc. So I think that there is a larger number of homeless than just 1,000, but 1,000 is the number of people who are registered nightly in Ottawa, and that is 6,000 or 7,000 people per year, but 1,000 per night.
Great, thank you. And then, are there any subtle changes or emerging trends with the homeless populations that you've seen over the past 5 to 10 years, such as perhaps age, gender, ethnicity, things like that?
So there's two trends. I think we have to think about who's homeless, and I'll mention that in a minute. And then what's the environment like, how that environment has changed for them. So the we've seen significant changes. So at first, this was the domain of the adult male alcoholic, and very few women. And then we noticed that there was an increasing proportion of women over the years. And then we saw newcomers, we saw families, and then more laterally, we've seen elderly people who are finding themselves into the shelters. So the demographics of that 1,000 people has changed. We're also seeing youth as an increasing number. So it's become a much more diverse community. And it's very hard to talk about the homeless or those people experiencing homeless, because each community within that context has their own unique needs, differences, and circumstances. And so take, for example, our Indigenous community within the shelters. That's changed significantly. The newcomers have changed depending on where the sources of our immigration status have come from. And we see many people from Somalia or other places like that now evolving into our shelter environment. So those individuals, it's a very heterogeneous community now. And so I don't think it's really fair to just talk about the homeless as if they all have one unique perspective. At the same time, I think it's important to recognize what's happened to the numbers have gone up and has stabilized to some extent. But we've seen the issue of mental health, and we've seen the issue of addiction becoming just so much more prevalent. And with as I mentioned earlier, with the advent of fentanyl and the metabolites like carfentanil and the toxic drug supply, addiction care and management has been so much different. We have crystal meth now. We've always had crack cocaine. I used to say that it couldn't get worse when we had crack cocaine. So I never say anymore that it can't get worse, because my perspective is I've always been proven wrong. And so the environment has changed. The people have changed. It's become a much more unstable, chaotic, violent world on the shelters.
Great, thank you for that. And then you've talked about the community's role, and you've said that individuals, you've encouraged them to say hi to people as they pass them. But is there anything else that you would recommend that individuals can do to help?
Oh, absolutely. I would hope that saying hi was not where it would end. There is a lot that we can do. We can we can volunteer. We can get engaged in this community. We can speak about our concerns to our local municipal representatives. We can help in different programs and bring different skills of teaching and education, etc. There are just so many needs and so many opportunities for us to become part of this community. And frankly, it's so rewarding and so much fun that I would encourage everybody to do it. And, I think when we own this problem, then I think we'll find the solutions. But at the moment, I have to say that it's probably not on most people's radar until they drive up to their cottage and then past King Edward and Murray.
And you mentioned that individuals can speak to their local representatives about this. Do you have any suggestions or ideas about what new policies could help reduce homelessness?
Yeah, so the new policies, there are many. So I think we found, not because we were smart, but only because it evolved this way, but we found that there was a need, once we stabilize individuals, there's a need for us to move into transitional housing and then onto permanent housing and reconnect people to environments that are more positive for them, like connecting them with family and the likes. We need to wrap around healthcare, mental health, physical health, and strategies that help those people reintroduce into the community. So those policy decisions that would support transitional supportive housing, as Jack had mentioned earlier, are essential. But I think then we need to have policies in place that allow us to identify people at risk, and policies that are going to be the most challenging are ones that are going to enhance access to education and employment and poverty reduction strategies and early childhood development strategies. Those policies are going to really be the test of our community and our society if we're going to tackle this problem.
And then can you describe for our audience how primary, even tertiary care is being delivered to the homeless in Ottawa on the streets?
Yeah. So we have an absolute army of volunteers, personal support workers, peers, nurses, and nurse practitioners, and a few dedicated physicians. And each one of the shelters, and then I'll mention about transitional housing units in a minute, but in each one of the shelters, we have nursing wards where individuals who are at risk needing support will receive health services, mental health, physical health, all culturally appropriate and trauma informed. And in that context, so if you were to go to the Salvation Army today, to the third floor, you would see the medical ward. If you went to the Union Mission, you would see a palliative care unit, the hospice, and beside that, you would see a primary care clinic driven by nurses and nurse practitioners. If you were to go to Shepherds of Good Hope, you would see our ambulance diversion service, our safe injection facility, and other programming that would help them. And so those, we actually have nursing units in each one of the shelters, and physicians provide care and support to those nursing units. And we also then, because we had to grow and we had people stabilized and we need to put them in a stable environment, so we've developed transitional housing units right across the city, which we also provide with nursing care, physician care, and other supportive social services.
And then what is the best way to support these particular initiatives, and what is the point of entry for getting involved?
Well, there's many different ways and routes to get involved, and you can do it through established organizations, whether that be church-based or through shelter-based organizations. You can do it through, depending on what you wish to do, through advocacy or evidence, depending on your perspective. So there's many different ways to get engaged. I would love to see us working much more in concert between community health centers, inner city, paramedics, hospitals, housing, judicial. I'd love to see this being more of a hub and spoke type model where we'd all work much more closely. And then we would have one opportunity for everybody to see where they could get engaged. And at the moment, it's a bit hodgepodge. So looking at the different partners, approaching those different partners to see where that you could find yourself, depending on your particular interests and your expertise.
Thank you. And then Can you give any examples of neighborhoods, cities, or countries that you feel have been more successful in caring for their homeless neighbors and citizens?
Um, that's also a good question, and that who's really solved this problem, and it kind of depends about what you look at where the problem is. If you look at Scandinavia, the inequity that exists within their communities it seems to be much less, and they seem to have less challenges than we do. If you look at countries that are trying to challenge the traditional dogma of the war on drugs, such as Portugal, they seem to have had some success in terms of their approach to addictions. So different places have different success rates. We have a really good track record in dealing with an integrated model of care, but we need to do so much more in terms of housing and poverty reduction strategies.
And then, is there a palliative care program for our homeless? This person says that they're sure they would have pain management, but what about the caring and human bedside companionship as they face the end of their life?
Yeah, so we do have a palliative care program. It's the Union Mission. It's been with us right since the beginning, and it has been a model for the rest of Canada. And there we support those individuals right in their community. So, if you were to take one of our homeless individuals and then suggest that they go to some other residential hospice, they would be out of their community and be very, very difficult for them. In that setting, we try and provide them services that they have identified that they need. That might be cultural services, that might be services that relate to just reconnecting with family. It may be all of those, religious services, et cetera, depending on what their needs and wants are. And of course, there we focus as well on pain and symptom management. But what we found is that out in the community, and those people who are unstably housed, they get no services, just about zero. And so we heard from some of our people who come into the palliative care unit and they say, we're now dying and we've got this wonderful facility. People are all over us, they're giving us pain and symptom management. We get good food and support in a private room. It's wonderful. Where were you for the last year and a half while I suffered in a single room occupancy facility in some of our rooming houses throughout the city? And we've recognized that the need for us to deal with pain and symptom management, advanced care planning, and chronic palliative care is profound out in the community. And we have not done that. And that's where we need to be.
And then you mentioned earlier that 1,000 is the number of people that are registered with the shelters. Is that the limit that the shelters are able to house?
We're almost always at our limit, to be honest with you. So 1,000 is just about our maximum during the summer. Of course, because it's summer, people will often sleep outside. In the winter, if you're exceeding 1,000, we probably then putting people in chapels on the floor and out into accessory sites that we could find. In the winter, our biggest challenge is to make sure that people are inside and fed and supported. And we have a wonderful community outreach around us that when we fill beyond 1,000 acute care beds, and other people would know the exact number better than I, but then you go to your capacity by using up all your floor space. And beyond that, then we have to reach out to our partners.
And then we have just a couple more questions that we have time for today. You talked about advocacy, and this person says that advocacy is a tricky dynamic. It's critically important, but can be viewed by the government and funders as oppositional. Do you think coalitions of community groups can champion change without losing strong cooperation with decision makers and funders?
Yeah. When does advocacy become sort of effective? If we're gentle and cooperative and collaborative, that would be most ideal. And we would think that our municipal, provincial, and federal colleagues would just improve and do what's right. But sometimes advocacy has to go beyond and make people uncomfortable. And then will that change the dynamic in terms of how you're viewed as a supportive colleague in trying to resolve this problem? It's a tough one. But my experience is that most decision makers, unless this problem is making them uncomfortable in somehow, will probably not respond to it. I hate to say that, but I think that comes after 20 years of experience, that you just have to kind of make people uncomfortable. And there's a begrudging respect and a willingness to work with you in the future if you're thoughtful and understanding, but firm.
And then our final question that we have the time for today is, can you please describe examples of how your patients receive better or well-suited care at shelters rather than in emergency?
So I can help you with that from the perspective of the chief of staff and the head of the Department of Medicine at the Ottawa Hospital in my past, and from the perspective of inner city. So one of our guys was up in the emergency department 181 times in the 6 months before coming into the program. And if you think about that, that's pretty well a full-time job. He would go, and I would see these people constantly. They would be found intoxicated, in some degree of distress in the emergency department. Fire, 911, police, paramedics up to the emergency department, wait 4 to 6 hours for an offload, seen by the emergency room physician, stable, discharge. And that would be it. They would have to now walk home from the general campus down to downtown, often in the winter. No subsequent care, no subsequent intervention. And as a result, that was a very expensive enterprise for that individual and didn't lead to any improvement in their care. If I see that person, they come to us instead of going to the emergency department. We can stabilize them. We can then say, hey, how about that foot? Can't I fix that foot for you? You've got an infection there. And do you want to keep raging with alcohol? Or why wouldn't you come into a treatment program with us? And by the way, we can put you in a stable environment where we start to manage those problems. And that leads to recovery, not the first one, the second one. And when I do it, it's a fraction of the price in the emergency department. And when I'm up in the emergency department and I see those individuals, it's frustrating as can be because they get very poor care. And I'm the one meant to be delivering that care. But if I'm downtown, I can give them better care for a fraction of the price.
Excellent. Thank you so much, Jeff, for your response to all of these questions. I think that that's
No.
been really enlightening and helpful for the people that have been watching. I'd like to take this opportunity to invite Louise Hanvey to come back up on our screen and give us some closing remarks before we end today's session.
It was my pleasure, by the way. Thank you.
Well, Jeff, you've given us so much to think about, but I also had so much emotion as I listened to this last hour and a half, recognizing maybe some of the things that I as an individual and I as a part of a community have tried to do, and things that I quite frankly have not tried to do, that I've learned today that I can do. And so I think you've given us a lot of ideas about what we can do as individuals and what we can do as Compassionate Ottawa to work with our community, to work with your community, to bring meaningful change. And I think that's certainly all of our goal. And Jack, I'd like to thank you for leading this conversation for Compassionate Ottawa with Jeff. It's been superb. I know that I've been following the chat and the Q&A. There's lots more comments and lots more engagement from our community. So thank you very much.
My pleasure.
Thank you, Louise.